Mhm. Hello everyone. Hi all. So wishing you all the best for your university examination. We'll start this session and we'll cover the important clinical cases from the biochemistry topic. We'll discuss the important clinical cases from the biochemistry topic, but this will be a superficial discussion because there are near about 60 to 65 cases from biochemistry which are there in that can be asked in the university examination. This is important topic. Here आपके लिए एक होमवर्क है, नहीं होमवर्क नहीं बोल सकता, जस्ट नोट डाउन द नेम ऑफ द केसेस. जैसे जैसे ये सेशन चलते रहेगा आपको नोट डाउन करना है वो केस का नाम, और जो भी किताब आप पढ़ रहे हैं वो किताब के फर्स्ट पेज पे, मतलब जैसे आप कार्बोहाइड्रेट ओपन करते हो तो कार्बोहाइड्रेट के फर्स्ट पेज पे आपको वो केसेस, क्लिनिकल केसेस आपको नोट डाउन करने हैं कि ये चैप्टर में ये क्लिनिकल केसेस इंपॉर्टेंट है. तो ये क्लिनिकल केसेस या तो क्लिनिकल केस बेस्ड सिनेरियो में पूछे जा सकते, या ये शॉर्ट नोट करके भी पूछे जा सकते. ऑल्सो दीज आर वेरी वेरी इंपॉर्टेंट फॉर द प्रैक्टिकल वाइवा. दैट्स व्हाई दिस टॉपिक is important. Early clinical exposure or clinical cases or clinical case based questions means what is probable diagnosis, which molecule is deficient is there, which enzyme is deficient, that type of question will be there from this topic. So we'll discuss this topic in the revision format. So we'll discuss this. See, in the early clinical exposure, apart from these four clinical cases, that is acute myocardial infarction, pancreatitis, hepatic jaundice, and obstructive jaundice, these are the four important clinical cases related from the enzyme topic, related with enzyme topic. Apart from these clinical cases, there can be a question on competitive inhibition. Competitive inhibition, this is also a clinical topic. Competitive inhibition, various drugs which are used in the competitive inhibition. For example, statins group of drugs which inhibit the enzyme HMG coenzyme reductase. This can be asked from the enzyme topic. So statin, lovastatin, atorvastatin, simvastatin, this group of drugs, they are inhibitor of enzyme HMG coenzyme reductase and reduces the cholesterol synthesis in the patient with coronary artery diseases or in patient with atherosclerosis. So this can be asked in the competitive inhibition. So this is also a clinical topic. Clinical topic means it is not only the cases, the drugs which are used in the practice, they are also the clinical related questions. So here are four important cases, that is acute myocardial infarction. So how will you diagnose myocardial infarction? Remember, whenever there is chest pain, acute chest pain, it indicates the myocardial infarction for related with the first MBBS student. Acute chest pain, if there is sudden onset of chest pain, perspiration, breathlessness, along with the ECG changes. So two key features are there here. See, two key features. One is the chest pain. Chest pain. Second one is the ECG changes, electrocardiogram changes. For example, ST elevation, T wave inversion, in that format, if the question is asked, so the your diagnosis is acute myocardial infarction. उसके नीचे में सब क्वेश्चंस रहेंगे. What are the markers? Which is the earliest marker? What are the different enzymatic markers? So there are number of enzymatic markers. For example, CKMB, creatine kinase MB isoenzyme, then troponin I, troponin T, these are the different markers. Then SGOT, which is a late and non-specific marker, LDH1, which is a specific but late marker. So CKMB and troponins, these are the important bedside testing. Means this troponins, they are used as a point of care testing, near patient testing, मतलब पेशेंट के बेड के साइड में हम ये कार्ड, जैसे प्रेगनेंसी टेस्ट रहती है उसी टाइप में ये इनके कार्ड टेस्ट रहते हैं, ट्रोपोनिन आई एंड ट्रोपोनिन टी. So that can be used in the point of care testing. So these are the different markers. So you may get a LAQ or SAQ related with the marker, and the course of this marker is important. So this is acute myocardial infarction. This case can be asked along with the hyperlipoproteinemia, that is type 2A. Acute myocardial infarction can be asked in combination with hyperlipoproteinemia, that is type 2A. LDL receptor defect or ApoB defect. In this defect, there is familial history of coronary artery diseases. So remember that this can be a question on lipoprotein metabolism, integrated topic, enzyme with lipoprotein metabolism. So this is acute myocardial infarction. Now second case is pancreatitis. So in the clinical case, there may be a history of abdominal pain. Remember, severe pain in the abdomen in the pancreatitis. So clinical history, pain in the abdomen. In acute pancreatitis, there may be fever, pain in the abdomen, fever, and raised level of enzymes, increased, that is amylase. But amylase is not specific for the pancreatitis. Amylase level also increases in the salivary gland infection. So in the mumps, in orchitis, the amylase level also increases apart from the pancreatitis. So this is not specific. So lipase, serum lipase level is more specific than the amylase. This is important MCQ related with this pancreatitis. So amylase and lipase level, they are raised in the pancreatitis. So this can be a clinical case. Okay, pancreatitis, acute pain in the abdomen, fever, and increase amylase level, increase lipase level. So the diagnosis is pancreatitis. Then hepatic jaundice, obstructive jaundice, various types of jaundice. This is integrated topic between enzyme, then the hemoglobin metabolism, लीवर फंक्शन टेस्ट, एंजाइम, हीमोग्लोबिन मेटाबॉलिज्म, लीवर फंक्शन टेस्ट, ये तीनों जगह पे आते हैं. hemolytic, hepatic and obstructive jaundice. See, in the hepatic jaundice there may be a flu like symptoms, because most common cause is the viral hepatitis. So here flu like symptoms, fever, nausea, omitting this the symptoms like this, and the marked raised activity of SGPT, SGOT, serum glutamate pyruvate transaminase, serum glutamate oxaloacetate transaminase levels, they are raised. Apart from this, there is increase in the hepatic jaundice, both type of bilirubin, that is direct and indirect. Both type of bilirubin increases in the hepatic jaundice. So increase in the both type of bilirubin, that the meaning is biphasic Vandenberg reaction and raised liver enzymes, that is SGPT, SGOT, along with the obstructive enzyme, that is alkaline phosphatase, slight raised alkaline phosphatase activity, it is seen in the hepatic jaundice. In the obstructive jaundice, there is abdominal pain. In the clinical case, the case history may suggest the abdominal pain or pruritus. Pruritus means itching because of increased bile salt level in the obstructive jaundice. So as there is obstruction is there, so that causes the pain. So obstructive jaundice causes are carcinoma of the head of the pancreas. The most common cause is the common bile duct obstruction, CBD, stone, stricture, tumor, tuberculosis, or the gallbladder diseases in which obstructive jaundice occurs, obstruction to the flow of bile occurs. In obstructive jaundice, there is marked increase in the alkaline phosphatase activity, ALP, because ALP is present, biliary form of the isoform of the alkaline phosphatase, it is present on the outer surface of biliary canaliculi. It is an ectoenzyme present on the outer surface of biliary canaliculi. When there is obstruction to the flow of bile, regurgitation of bile occurs and irritation of bile epithelium. irritation of this outer surface of the bile epithelium causes release of alkaline phosphatase in the serum, and level of alkaline phosphatase mark increase. Near about 10 to 12 time increase in the alkaline phosphatase level occurs in the obstructive jaundice. Alkaline phosphatase level also increases in the bone diseases, marked increase more than 25 times of the normal. It is in the rickets, it is in the osteomalacia, it is in the Paget disease of the bone, also in the different cancer where metastasis in the bone occurs. In that cases, the alkaline phosphatase level, it is more than this obstructive jaundice. This is 10 to 12 times of the normal. Here in hepatic jaundice, it is 2 to 3 times of the normal. So mark increase in the alkaline phosphatase activity, then there is increase in the 5' nucleotidase, then there is increase in the gamma glutamyl transferase, this activity, and slight increase in the SGOT and SGPT. So this is a picture, or these are the laboratory tests in the obstructive jaundice. So these are the 4 important clinical cases from enzyme topic: acute myocardial infarction, pancreatitis, hepatic jaundice, obstructive jaundice. Apart from this, competitive inhibition can be a question, clinical based question. So here in competitive inhibition, different examples, therapeutic examples of competitive inhibitors, that may includes the allopurinol. You may get case on the gout, in which we use the allopurinol, which act by the competitive as well as the suicide inhibition. Then methotrexate is the anti-cancer drug which is used as an competitive inhibitor. This is also a the integrated topic. Methotrexate, it is integrated topic in between enzyme, then the folic acid, vitamin, and the third one is the cancer. So it can be also a question in the clinical case. So competitive inhibition, different examples of competitive inhibition, they are important here. Okay, so these are the topics which are important from the enzyme topic. Now the second chapter, तो अभी जैसे हमने कार्बोहाइड्रेट चालू किया, सो कार्बोहाइड्रेट केमिस्ट्री एंड मेटाबॉलिज्म, these are the different clinical cases from carbohydrate chemistry and metabolism. So note down these cases on that chapter. मतलब जहाँ पे वो चालू होता है उसके ऊपर थोड़ी सी जगह होगी, तो वहाँ पे ये नोट डाउन करो, या तो एक पेज पेस्ट करो वहाँ पे और ये केसेस लिख लो. मतलब एग्जाम को जाते वक्त इसका आइडेंटिफिकेशन हमको आना चाहिए, इसमें क्या डिफिशिएंट है वो हमको आना चाहिए, और मेन की फीचर्स क्या रहेंगे जिसको देख के हम डायग्नोस कर सके ये डिसीजेस, ये हमको आना चाहिए. सो दिस इज इंपॉर्टेंट पार्ट रिलेटेड विद दिस क्लिनिकल केसेस. ओके, सो दीज आर द इंपॉर्टेंट क्लिनिकल केसेस फ्रॉम कार्बोहाइड्रेट केमिस्ट्री एंड मेटाबॉलिज्म. जस्ट वेट. Now see, these are the important clinical cases from carbohydrate chemistry and metabolism. Diabetic ketoacidosis, diabetes mellitus, galactosemia, that is classical galactosemia, von Gog's disease, glycogen storage disorder, glucose 6-phosphate dehydrogenase deficiency, HMP shunt, Pompe's disease, McArdle's disease, lactose intolerance, sucrose intolerance, Hurler syndrome, Hunter syndrome, and hereditary fructose intolerance. जब भी आप उसके की फीचर्स देखते हो, आपको याद आना चाहिए कि ये डिसीज हो सकता है. उसके बाद में आपको ये पता करना है कि ये कौन से पाथवे से रिलेटेड होगा, और इसमें कौन सा एंजाइम है या कौन सा मॉलिक्यूल है जो डेफिशिएंट है, उसके वजह से ये डिसीज होता है. ये चीजें हमको रिकलेक्ट करनी है. Okay, so diabetic ketoacidosis, diabetes mellitus, it is related with the regulation of blood glucose level, and it is related with the insulin and the glucagon, the glucose homeostasis by the various hormones. All of you know that all other hormones, they are they try to increase the glucose level, and insulin is only the hormone which decreases the blood glucose level, mainly by increasing the uptake of glucose inside the skeletal muscle, heart, and adipose tissue, and by decreasing or inhibiting the gluconeogenesis and inhibiting the glycogenolysis, while glucagon, epinephrine, and all other hormones, they try to increase the blood glucose level. Now in the diabetic ketoacidosis, see, in this diabetic ketoacidosis, this is very important clinical case, because it is connecting link between the carbohydrate metabolism, lipid metabolism, and acid base disorder. तीन जगह पे ये केस आती है diabetic ketoacidosis. इसके अलावा भी आप जब प्रैक्टिकल में यूरिन का वाइवा करते, यूरिन का प्रैक्टिकल करते हो, उसमें भी डायबिटिक कीटोएसिडोसिस आता है। एकदम सिंपल है डायबिटिक कीटोएसिडोसिस, आपको कुछ भी नहीं देखना है, आपको देखना है दो टेस्ट वहां पे दी हुई है क्या। कौन सी दो टेस्ट? वन इज द बेनेडिक्ट टेस्ट, वन इज द रोथरास टेस्ट। सो हियर बेनेडिक्ट टेस्ट for reducing sugar it is positive, and rothera's test is positive. रोथरास टेस्ट पॉजिटिव, बेनेडिक्ट टेस्ट पॉजिटिव, रोथरास टेस्ट पॉजिटिव, दोनों टेस्ट अगर पॉजिटिव लिखा हुआ है, गो विद द डायबिटिक कीटोएसिडोसिस। स्टारवेशन में सिर्फ कीटोन बॉडीज आते हैं, बेनेडिक्ट टेस्ट निगेटिव रहेंगे स्टारवेशन के केस में। Okay, so here in diabetic ketoacidosis, patient brought to the hospital in semi-conscious or the unconscious state. This is because of the metabolic acidosis and dehydration occurs in the diabetic ketoacidosis. किसके वजह से वो अनकॉन्शियस रहता है? या तो डिहाइड्रेशन की वजह से, या तो मेटाबॉलिक एसिडोसिस की वजह से वो अनकॉन्शियस रहता है। एंड डीप एंड रैपिड रेस्पिरेशन इज देयर, दैट इज नोन एज कस्माउल ब्रीदिंग, विच इज ए कॉम्पेंसेटरी मैकेनिज्म to blow out the CO2 to compensate the metabolic acidosis. There is deep and rapid respiration, that is known as Kussmaul breathing. That is known as Kussmaul breathing. So remember, whenever there is positive Benedict test, positive Rothera's test, whenever there is history of diabetic, patient brought to the hospital in semi-conscious or unconscious state with deep rapid breathing, that is Kussmaul respiration, and there is acid base disturbances, means the if the bicarbonate level, pH and the PCO, partial pressure of CO2 is given, that indicates the diabetic ketoacidosis. Okay, so Rothera's test positive, Benedict test positive. Rothera's test, it is given by the ketone bodies. Ketone bodies, acetone and acetoacetate gives Rothera's test positive. Beta hydroxybutyrate, it is a false ketone body. It contains hydroxyl group. It does not give the Rothera's test positive. For that, modified Rothera's test is needed for the beta hydroxybutyrate to give the test positive. Now, in diabetic ketoacidosis, as there is insulin deficiency, all of you know that what is complication of what is metabolic complication of diabetes? There is deficiency of insulin. Diabetes is because of insulin insufficiency, and as there is decrease insulin level, glucose uptake inside the cell decreases. Uptake inside the cell decreases, means the glucose transporters which are dependent on the insulin, they will not work. For example, the skeletal muscle, heart and adipose tissue, GLUT4, it is dependent on insulin, so it will not work. So decrease glucose uptake in the insulin deficiency. So there is and increase as there is in the cell there is no glucose inside the cell, so there is stimulation of uh, glucose level. So the gluconeogenesis is stimulated, glycogenolysis is stimulated because of low glucose level inside the cell. So as these two pathways, they are stimulated because of elevated levels of other hormones in comparison with the insulin, there is increased glucose level that causes hyperglycemia, and because of the hyperglycemia it crosses the renal threshold, that is 180 milligram per deciliter, which is the renal threshold. उसके ऊपर अगर blood में sugar गया तो it started appearing in the urine, that is known as renal threshold 180 milligram per deciliter. As it started appearing in the urine, it drags water with it. मतलब ग्लूकोज यूरिन में आ रहा तो अपने साथ साथ पानी भी लेके जा रहा, सो दैट कॉजेज द डिहाइड्रेशन, दैट causes the three cardinal symptoms of diabetes mellitus, that is polyuria, polyphagia and polydipsia. Polyuria, polyphagia and polydipsia. So these are the three cardinal signs of diabetes mellitus, symptoms of diabetes mellitus. Raise blood glucose level. यहाँ पे आपको प्लाज्मा ग्लूकोज की फास्टिंग, पोस्ट मील और रैंडम ब्लड ग्लूकोज की वैल्यू आपको पता चाहिए। HbA1c ग्लाइकेटेड हीमोग्लोबिन क्या चीज है ये आपको पता चाहिए। दैट मे बी ए सब क्वेश्चन इन द डायबिटीज मेलाइटस। ओनली इफ बेनेडिक्ट टेस्ट इज पॉजिटिव, the blood glucose level is more than normal, here the WHO criteria for diagnosis of diabetes mellitus is important. If the fasting plasma glucose it is more than 126, and if the post meal plasma glucose it is more than 200, it indicates the diabetes mellitus, diagnosis of diabetes mellitus, fasting and post meal. See, 70 to fasting level 70 to 100, fasting level 70 to 110 is the normal range. 110 to 126 means 125, it is 126, it is pre-diabetic, or that is known as impaired glucose tolerance, and more than 126 it is diabetes. It is diabetes mellitus, fasting plasma glucose level. Post meal glucose level, it is 110 to 140 is normal, 140 to 200 is the pre-diabetic or impaired glucose tolerance, and more than 200 is diabetes. So increase plasma glucose level. Benedict test on the urine sample is positive. These symptoms, polyuria, polyphagia, and polydipsia, along with the complication, that is metabolic complication, means increase in the lipid levels. Hyperlipidemia is there. Hyperglycemia is the diagnostic criteria. There is increase in the glycated hemoglobin, that is HbA1c, which is non-enzymatic attachment of glucose to N-terminal valine of the beta globin chain. So that forms the glycated hemoglobin, which tells the average blood glucose level for the preceding 2 to 3 months. Preceding 2 to 3 months, 6 to 8 weeks, average blood glucose level. This is dependent on RBC lifespan. Okay. So this is diabetes mellitus. So diabetic ketoacidosis मतलब Benedict test positive, Rothera's test positive, patient को unconscious और the semi conscious state में लाएंगे, and along with their Kussmaul breathing, and there is metabolic acidosis, means pH decrease रहेगा, bicarbonate level. Bicarbonate is utilized for buffering the ketone bodies, so that's why acidosis is there in the diabetic ketoacidosis. There is metabolic acidosis. Diabetes mellitus, it is simple polyuria, polyphagia, polydipsia is there, and the increased blood glucose level. So plasma glucose level increased, increased plasma glucose level, fasting more than 126 and post meal more than 200. Glycated hemoglobin more than 6.5%, that indicates the diagnosis of diabetes mellitus. Okay. Now the galactosemia. Galactosemia, classical galactosemia is the important clinical case. In galactosemia, this is again important, very very important clinical case, galactosemia. कौन से मेटाबॉलिज्म का डिफेक्ट है? गैलेक्टोज मेटाबॉलिज्म का डिफेक्ट है. कौन से एंजाइम के डिफिशियंसी से होता है? गैलेक्टोज 1 फॉस्फेट यूरिडिल ट्रांसफरेज. दिस इज इंपॉर्टेंट क्लिनिकल केस, गैलेक्टोसेमिया, गैलेक्टोज 1 फॉस्फेट यूरिडिल ट्रांसफरेज. नाउ सी हियर, दिस इज गैलेक्टोज मेटाबॉलिज्म. अगर आप लोगों ने गैलेक्टोज मेटाबॉलिज्म नहीं पढ़ा है तो इतना पढ़ लो गैलेक्टोसेमिया में, जितना मैं बताता हूँ अभी आपका गैलेक्टोज मेटाबॉलिज्म हो जाएगा. सो सी गैलेक्टोज हियर, galactose, it is converted into galactose 1 phosphate, galactose 1 phosphate, which is converted into UDP galactose, which is converted into UDP glucose, UDP galactose, UDP glucose. Okay, so galactose is converted into galactose 1 phosphate by the enzyme, that is galactokinase, then by the galactose 1 phosphate uridyl transferase. It is converted into UDP galactose, and by the epimerase it is converted into UDP glucose. So these are the three important enzymes in the galactose metabolism, and these are the steps in the galactose metabolism. This is all about the galactose metabolism. Now what is block here? Now see here, when there is block in the galactose 1 phosphate uridyl transferase activity, it causes classical galactosemia. It causes classical galactosemia, and all other symptoms of galactosemia, it is because of accumulation of this compound. Which compound? This galactose 1 phosphate. It accumulates. So when it accumulates in the brain, it causes the mental retardation. When it accumulates in the liver, it causes the hepatomegaly. It decreases the conversion of galactose into glucose. Also, it inhibits the glycogen phosphorylase enzyme of the glycogen metabolism and decreases the glucose synthesis. So, it causes the hypoglycemia. So, what are the symptoms here in the galactosemia? That is hypoglycemia, decreased blood sugar level. Hypoglycemia. Then the jaundice. Accumulation of galactose 1 phosphate in the liver decreases the uptake of bilirubin by the hepatocytes. So jaundice is there. Then mental retardation in the brain. So this galactose in deficiency of galactose 1 phosphate uridyl transferase, it is diverted, it is excreted in the urine, and it is diverted for the production of dulcitol, or another name is galactitol, and this causes the opacity in the lens, that is cataract, congenital cataract in the galactosemia, congenital cataract, which is known as oil droplet cataract, oil drop like appearance. This is by the aldose reductase enzyme. So this is very important clinical case, galactosemia. तो इसमें क्या होता है, यूरिन में गैलेक्टोज जाता, सो बेनेडिक्ट टेस्ट ऑन द यूरिन इज पॉजिटिव, बेनेडिक्ट टेस्ट ऑन द यूरिन इज पॉजिटिव, रिमेंबर बेनेडिक्ट टेस्ट पॉजिटिव है, हम सोचते हैं कि सिर्फ ग्लूकोज ही बेनेडिक्ट टेस्ट पॉजिटिव देता है, इट इज बाय द रिड्यूसिंग शुगर, सो गैलेक्टोज गिव्स द बेनेडिक्ट टेस्ट पॉजिटिव। लेकिन गैलेक्टोज जो है, जो हम रूटीनली ब्लड लेवल मेजर करते हैं, वो टेस्ट से गैलेक्टोज नहीं मेजर होता, सो ग्लूकोज यहाँ पे हाइपोग्लाइसेमिया है, ब्लड ग्लूकोज विल बी लो and the urinary galactose level is more. This can be a picture in the galactosemia, remember this. So and all symptoms of galactosemia, it is because of accumulation of galactose 1 phosphate. So this is very important case, classical galactosemia, galactose metabolism, and this is galactose metabolism. In short, this is galactose metabolism. Okay, so this is all about the galactosemia. Okay, now the glycogen storage disorder, three glycogen storage disorder, they are very important. First one is, so first is the von Gog's disease, second one is the Pompey's disease, and third one is the McArdle's disease. Von Gog's disease, Pompey's disease, and McArdle's disease. These are important, and these can be a question, clinical case-based question in the university examination. Von Gog's disease. So typical blood picture in the von Gog's disease. Now here which enzyme is defective in the von Gog's disease? It is glucose 6 phosphatase. Now we'll discuss the von Gog's disease. Now see. Glycogen storage disorder type 1. Von Gog's disease. Type 1. Glycogen storage disorder. So versatile player Corey Anderson made his glycogen versatile. Von Gog's disease, Pompey's disease, player Pompey's disease, Corey's disease, Anderson's disease, Corey Anderson, McArdle's disease, Her's disease, and these are related with the glycogen metabolism disorders, glycogen storage disorders. So there is accumulation of glycogen occurs in this glycogen storage disorder, and liver biopsy help in the diagnosis of glycogen storage disorder. And different enzymes, their levels affected in the glycogen storage disorder, that's why there is accumulation of glycogen occurs in the various tissues. So that mainly affect the liver, that mainly affect the muscles. Okay, so some are liver glycogen storage disorder, some are muscle glycogen storage disorder. Muscle glycogen storage disorder, that includes the McArdle's disease, Pompey's disease. Mainly McArdle and Pompey's disease, they involves the muscle, while the rest of the glycogen storage disorders, they are hepatic glycogen storage disorder. Now von Gog's disease, which enzyme is defective? Glucose 6 phosphatase. This enzyme is defective in the glucose 6 phosphatase, this enzyme. Now this enzyme, it is absent in the muscle, so muscles are not involved in the von Gog's disease. Muscles are not involved in the von Gog's disease. So it is hepatorenal. So now see this pathway. Glucose 6 phosphatase. What is the role of glucose 6 phosphatase? Glucose 6 phosphate, it is converted into glucose. If it is absent, if there is decreased activity of glucose 6 phosphatase enzyme, decreased activity of glucose 6 phosphatase enzyme, this is a common enzyme for the glycogenolysis and also for the gluconeogenesis. मतलब ग्लाइकोजिनोलाइसिस का भी एंजाइम है और ग्लूकोनियोजेनेसिस का भी एंजाइम है, ग्लूकोज 6 फॉस्फेटेज। अगर ये कम रहेगा, सो इट कॉजेज द फास्टिंग हाइपोग्लाइसेमिया, इट कॉजेज hypoglycemia. This is feature, fasting hypoglycemia, because of decreased conversion of glucose 6 phosphate into the glucose, hypoglycemia. Now accumulation of this glucose 6 phosphate, it is it is a substrate, it is a starting substrate for which pathway HMP shunt, it goes into HMP shunt, and in the HMP shunt there is production of ribose 5 phosphate, ribose 5 phosphate, and this is a precursor for AMP, adenosine monophosphate, inosine monophosphate, guanosine monophosphate, and in their degradation there is production of uric acid occurs, there is production of uric acid occurs. So there is hyperuricemia in the von Gog's disease. Apart from this glucose 6 phosphate, it is diverted, it goes in the glycolysis, it produces the lactate. So there is lactic acidosis, it produces the acetyl coenzyme A, acetyl coenzyme A, and acetyl coenzyme A, it is diverted for the fatty acid synthesis, fatty acid and cholesterol synthesis. So there is hyperlipidemia in the von Gog's disease. So hypoglycemia, hyperuricemia means increased uric acid level. There is increase in the cholesterol. There is increase in the triglyceride level in this patient of von Gog's disease. There is increase in the lactic acid level. Lactic acid level. There are two reasons for the increase in the uric acid level, which can be a sub question in the von Gogh disorder, von Gogh disease. Now see, first is the this ribose 5 phosphate and uric acid synthesis, and second lactic acidosis, which is there. Lactate causes the retention of uric acid. It competes with the urate, it competes with the uric acid and causes the retention of uric acid, so by in the renal tubule, that's why there is increase in the uric acid level. So hypoglycemia, increase uric acid level, increase cholesterol and TG, increase in the lactic acid level in the von Gog's disease. So there is fatty cheeks means doll like faces, protuberant abdomen due to hepatomegaly, then hypoglycemia, increase hyperuricemia, increase cholesterol and TG, increase lactic acid level, and the deficient enzyme is glucose 6 phosphatase. So here hepatoreinomegaly occur. Hepatoreinomegaly occur. So spleen is not involved, muscles are not involved in the von Gog's disease. So this is glycogen storage disorder type 1, type 1A. Glycogen storage disorder, von Gog's disease. Now in the Pompe's disease, see this is Pompe's disease, this is muscle glycogen storage disorder. It is characterized by hypotonia. There is involvement of heart, muscle and liver. Liver is also affected, but muscles are, they are more predominantly involved because of deficiency of acid maltase. So this is because of defect decrease in the lysosomal acid maltase. This is also known as lysosomal storage disorder. Pompe's disease, it is also known as lysosomal storage disorder. There is involvement of heart, liver and muscles, they are predominantly involved. So there is hypotonia, floppy infant is there, and in Pompe's disease death occur due to cardiac involvement, heart involvement. 18 month to 2 year, the death of the child will occur in the Pompe's disease, can occur in the Pompe's disease. So it is muscle glycogen storage disorder, affect the muscle. There is hypotonia, there is involvement of heart, cardiomegaly, deposition of the glycogen in the heart. It is because of defect in the lysosomal acid maltase, Pompe's disease, and uh, it is in the Pompe's disease, the hypotonia, heart involvement, tongue involvement can be there, and early death occurs. Myocardial disease, muscles are only involved. This is due to muscle glycogen phosphorylase defect, and exercise intolerance is the predominant feature of the myocardial disease. This is again a frequently asked clinical case in the university examination. Myocardial disease. In myocardial disease, see this is Pompe's disease. In Pompe's disease, there is decrease activity or defect in the lysosomal acid maltase. So because of defect in lysosomal acid maltase, so there is accumulation of glycogen in the heart, in the muscles, and liver is also involved. There is also tongue enlargement occurs, and death occurs in 18 months to 2 years of age because of involvement of the heart. It is also known as lysosomal storage disorder. And the predominant features are hypotonia, flaccidity, hypotonia, flaccidity. These are the important features in the Pompe's disease. Now the McArdle disease, see, McArdle's disease, it is because of muscle glycogen phosphorylase defect, muscle glycogen phosphorylase defect. Glycogen phosphorylase causes the conversion of glycogen into glucose. So there is accumulation of glycogen in the muscle, and the predominant feature is exercise intolerance. Intolerance. This is predominant feature. Apart from the exercise intolerance, there is second wind phenomenon, that is second wind phenomenon, in which if you pause or if you rest for some time, you can resume your activity with little discomfort. And if you proceed further, if you continue your exercise, in that case the burgundy color urine may be there, passage of burgundy color urine may be there because of rhabdomyolysis. This is McArdle disease, in which muscle glycogen phosphorylase is defective. Okay, so these are the three glycogen storage disorders. They are important: von Gog's disease, Pompe's disease, McArdle disease. Accumulation of glycogen in the tissues, mainly in the liver and muscle. This is liver glycogen storage disorder. Pompe's and McArdle, these are the muscle glycogen storage disorder. Now, these are the important clinical cases. Then G6PD deficiency. G6PD deficiency, it is related with the HMP shunt. It is related with HMP shunt, hexose monophosphate shunt, glucose 6 phosphate dehydrogenase deficiency. It is X-linked recessive disorder, mostly affect the males. G6PD deficiency mostly affect the males. It is related with the NADPH production, means if there is G6PD deficiency, there is decrease in the NADPH production. NADPH, it is required, it is antioxidant function, and it prevents the hemolysis of RBCs. In absence of this G6PD deficiency, just wait, we'll discuss this. G6PD, glucose 6 phosphate dehydrogenase deficiency, glucose 6 phosphate dehydrogenase. This enzyme, it is of HMP shunt. What is produced in the HMP shunt? Ribose and NADPH. What is the role of NADPH? It is an antioxidant. Antioxidant. So when the person is affected with G6PD deficiency, there is decreased production of NADPH in that patient. But as such, the patient is asymptomatic. But when he is exposed to the oxidant drugs, when he is exposed to the oxidant drugs or infections, or when he consume fawabins, in that case there is this oxidant drugs and the infection or the fibrin consumption that stimulates or causes or accelerate the production of reactive oxygen species or the free radicals. And as this pathway is affected here, NADPH production is very low. NADPH, it is required for the glutathione reductase activity, which is important for the synthesis of reduced glutathione, and reduced glutathione maintain the RBC membrane integrity. So because of decreased NADPH level, as in this there is decreased NADPH level, means decrease activity of glutathione reductase, decreased level of reduced glutathione, so that causes the damage to the RBC membrane. So this reactive oxygen species, in absence of this there is hemolysis. So damages red blood cell, rapid hemolysis will occur, and that causes the jaundice and the anemia. It causes jaundice and anemia. So it is drug induced hemolytic anemia. G6PD deficiency, it causes drug induced hemolytic anemia. Drug induced hemolytic anemia. This is important. It is related with HMP shunt. HMP shunt is an important short note. So this can be a assay type, clinical case based assay type question. This is very important. So this is G6PD deficiency, glucose 6 phosphate dehydrogenase deficiency. Now, lactose intolerance and sucrose intolerance, these are the simple clinical cases. It is related with digestion and absorption of lactose and sucrose. Now, when lactase enzyme which acts on the lactose into convert the lactose into a galactose and glucose. So here lactase is deficient, and when the child is shifted, when the neonate is shifted to the formula feed, and when milk is avoided, in that case the miracle will happen and the symptoms will be relieved. Lactose intolerance, there is production of gases because of fermentation of lactose. As it is not digested, the fermentation of lactose occurs, and that produces the gases, and that causes the abdominal distension and pain. So excessive cry, refusal to feed, vomiting, abdominal cramps, these are the symptoms of lactose intolerance. Similar is for the sucrose intolerance. It is in the adult. When we take the sucrose rich fruit, sucrose rich diet as table sugar, sugarcane juice, or the fruits, that causes the, because of deficiency of sucrase enzyme, this causes the same manifestation as that of the lactose intolerance. Here sucrase is deficient, here lactase enzyme is deficient. Hurler and Hunter syndrome, these are the mucopolysaccharidosis, MPS, mucopolysaccharidosis. There is accumulation of heparan sulfate and dermatan sulfate. So these two glycosaminoglycans, they accumulates in the Hurler and Hunter syndrome. These are known as mucopolysaccharidosis. And there is multi-system involvement in this disorder. In Hurler syndrome, there is defect in the iduronidase, and in Hunter syndrome there is defect in ronate sulfatase. Because of this defect in this enzyme, there is because of this hydrolases enzyme defective, there is glycosaminoglycans which accumulates in the various tissues. For example, if they are accumulated in the brain, they causes the mental retardation, they causes the skeletal damage, they causes hepatosplenomegaly. So mental retardation, coarse facial hair, hepatosplenomegaly, and the musculoskeletal or skeletal deformities, and the short stature, these are the symptoms of this mucopolysaccharidosis, Hurler and Hunter syndrome. Now see, only difference is that Hurler is the first. Remember, she is always first, so Hurler is always first and Hunter is the second. And Hunter requires the clear vision. So this is mnemonic to remember. So that's why there is no hazy cornea in the Hunter. In Hunter syndrome, it is clear cornea. This is autosomal recessive. This is X-linked disorder, Hunter syndrome. And the hereditary fructose intolerance, this is again autosomal recessive disorder due to defect in the enzyme aldolase. Aldolase B enzyme is defective in hereditary fructose intolerance. This we'll discuss this, just wait. हेरिडिटरी फ्रुक्टोज इंटॉलरेंस, इसके साथ साथ आपको फ्रुक्टोज का मेटाबॉलिज्म हो जाएगा. दैट्स व्हाई वी आर गोइंग टू डिस्कस दिस, क्योंकि हम जनरली ये स्किप करते हैं. तो सी fructose, it is converted into fructose 1 phosphate, and fructose 1 phosphate, it is converted into by the fructokinase. This is by the fructokinase, it is converted into fructose 1 phosphate, and this fructose 1 phosphate, it is converted into DHAP, dihydroxyacetone phosphate, and glyceraldehyde, and it enters the glycolysis. The minor sugars, they try to be converted into glucose and metabolize. So here is the enzyme aldolase B. If this is defective or this is deficient, aldolase B is deficient, so this is known as hereditary fructose intolerance. hereditary fructose intolerance. In this disorder, in this autosomal recessive disorder, there is defect in aldolase B and there is accumulation of fructose 1 phosphate. This causes same symptoms as that of the galactosemia. Galactosemia के symptoms याद करो. So there is jaundice, there is mental retardation, there is jaundice, there is hepatomegaly, hypoglycemia because of accumulation of this fructose 1 phosphate that causes this symptom. But this, as such, this is asymptomatic when person consume the fruits, fructose rich fruits, when he consume the table sugar, when he take the fructose rich diet or fructose rich diet, the precipitation of these symptoms occurs. Precipitation or manifestation of these symptoms occurs in terms of hypoglycemia, hepatomegaly, then hypoglycemia, hepatomegaly, then jaundice. These are the symptoms in the hereditary fructose intolerance. So these are the important clinical cases from the carbohydrate chemistry and metabolism. Okay, so these 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. 12 important cases from carbohydrate chemistry and metabolism. इसको नोट डाउन करके रखना है आपको, वो चैप्टर के स्टार्टिंग में जब आप एग्जाम के लिए पढ़ोगे तो साथ में आपको ये पढ़ने हैं. Okay, just wait. Just wait. Okay. So this is related with carbohydrate chemistry and metabolism. Now the lipid chemistry and metabolism, these are the important clinical cases. अभी ये सब diseases important थे. Now these two they are gaining the importance, that is type 1 familial chylomicronemia and the type 2A, that is familial hypercholesterolemia. These are the important clinical cases from the lipid metabolism, lipoprotein metabolism and related disorders. क्योंकि competency में clear lipoprotein metabolism और उनसे related diseases वहाँ पे लिखा है, एक मतलब उसका पूरा heading में लिखा हुआ है. So these are the two important clinical conditions from the lipid chemistry and metabolism. Respiratory distress syndrome, again important topic related with the dipalmityl lecithin. If there is deficiency of lecithin or dipalmityl lecithin, that causes the respiratory distress syndrome, particularly in the preterm neonates. So there is rapid respiration cyanosis of the lips, finger can occurs in the acute respiratory distress syndrome. Here it affects particularly the preterm neonate where lecithin synthesis or lecithin deficiency is there. So lecithin sphingomyelin ratio, it is less than 1 in the preterm neonate and it causes the acute respiratory distress syndrome. This is due to the defect in the respiratory or decreased respiratory surfactant that is dipalmityl lecithin. So there is role of dipalmityl lecithin which is defective in this disorder and that causes the collapse of the lung. This surfactant prevent the alveoli from the collapse at the end of expiration. So this is important. Gaucher's disease, it is the sphingolipidosis. It is because of the beta glucosidase or glucocerebrosidase defect in which there is wrinkled tissue paper or the crumpled tissue paper appearance is there. Wrinkled tissue paper macrophages, wrinkled paper microphages or wrinkled tissue paper or tissue paper macrophages because of accumulation of glucose cerebrosides because of defect in beta glucosidase. It affects the liver, spleen and bone marrow. So there is decreased cell count, so anemia, leukopenia, thrombocytopenia is there. There is avascular necrosis of the large bones, so femur is involved and the wrinkled paper tissue paper appearance of the macrophages is there. Sphingolipids, they are involved in the Gaucher's disease. Phrinoderma, it is multinutrient deficient condition in which there is deficiency of essential fatty acid deficiency. Also vitamin A deficiency causes the toad-like skin, toad skin, particularly involving the extensor aspect of the forearm. So that is phrinoderma, multinutrient deficient condition. Repsom's disease, here alpha oxidation defect. This is alpha oxidation defect. Because of defect in the oxidation defect, phytanic acid branch chain fatty acid. Phytanic acid is the branch chain fatty acid, and due to defect in the phytanic acid oxidase or phytanic acid hydroxylase, there is the oxidation of this alpha oxidation does not occur, and that causes the Refsum's disease. The symptoms are uh, ataxia, retinitis pigmentosa, neuropathy, ataxia, and retinitis pigmentosa. These are the features of this disease because of defect in the activity of phytanic acid oxidase or phytanic acid hydroxylase. Repsom's disease, alpha oxidation defect. Jamaican vomiting sickness, when we eat the unripe ackee fruit which contain the toxin hypoglycin A. This is toxin which is present in unripe ackee fruit, hypoglycin A, and this hypoglycin A inhibit the medium chain acyl coenzyme A dehydrogenase enzyme, and this blocks the beta oxidation pathway. So that's why there is hypoglycemia and vomiting in Jamaican vomiting sickness. The special fruits which is found in certain regions of the Africa, that is known as ackee fruit. So when the person consume unripe ackee fruit which contain the toxin hypoglycin A, that causes inhibition of acyl coenzyme A dehydrogenase, and that blocks the beta oxidation, and symptoms will be there. Zellweger syndrome, it is important, it is absence of functional peroxisome. So peroxisomes are not there or empty peroxisomes. This affect the very long chain fatty acid oxidation. Very long chain fatty acid more than 22 carbon, it is affected, and accumulation of very long chain fatty acid in the various tissue, particularly in the liver, brain, and the kidney, causes the cerebrohepatorenal disease. Cerebrohepatorenal disease. Profound neurologic impairment is there in the Zellweger syndrome, and death can occur within the 1 year of age. This is a severe form of Zellweger spectrum disorder, Zellweger syndrome. It is from the cell membrane topic, it is from the lipid metabolism. Then sudden infant death syndrome, there is the 10% cases of sudden infant death syndrome, they are thought to be because of the decreased activity of medium chain acyl coenzyme A dehydrogenase. Medium chain acyl coenzyme dehydrogenase. 10% cases, only 10% cases. Rest of the causes, they are not known. Sudden infant death syndrome. Death of the child occurs during the sleep when there is more than 12 hours of fasting. When there is more than 12 hours of fasting because of block in the beta oxidation pathway. So beta oxidation pathway, it provides the energy for the gluconeogenesis. So that's why there is block in the gluconeogenesis, block in the beta oxidation pathway, and the death of the infant occur in the children. Death of the infant occurs in the sleep, when there is more than 12 hours of fasting. The 10% they are thought to be due to blockade in the beta oxidation pathway. In the fatty liver, there is accumulation of fat in the liver, that is known as fatty liver. There are alcohol is the most common cause of fatty liver. Also diabetes mellitus, obesity, and there are multiple causes of fatty liver, but alcohol, diabetes, obesity, these are the important causes of fatty liver. Fatty liver, it is mainly because of increased triglyceride synthesis, which occurs in the alcoholic cases, increased triglyceride synthesis, and the decrease in the lipoprotein which moves this fat from the liver. So because of increased TG synthesis and decreased mobilization of fat from the liver, and increased mobilization from adipose tissue to the liver, that causes the fatty liver. So there are certain factors which prevent the fatty liver, it is known as the lipotropic factor. So SGOT, SGPT, liver enzymes, the levels, they are increases, and in advanced stage of the fatty liver there is cirrhosis of liver occurs, and the increase in the SGOT, SGPT levels may be there in the in that condition. Now these two important diseases, that is familial chylomicronemia and familial hypercholesterolemia. We'll discuss these two. See, if there is increased activity of chylomicron, if chylomicron levels are raised, chylomicron का function क्या है? Chylomicron carries the triacyl glycerol level. So increase chylomicron, increase triacyl glycerol. So whenever there is increase in the triacyl glycerol, there is increased risk of pancreatitis. There is increased risk of pancreatitis. As these lipids are increased levels of this lipid, they causes the eruptive xanthomas. They causes eruptive xanthomas, and there is increased risk of pancreatitis. Increased chylomicron gives the lipemic plasma or the milky plasma, lipemic serum or lipemic plasma or the milky plasma appearance because of very high levels of chylomicron, very high levels of Tg. And this occurs because of defect in the enzyme, that is lipoprotein lipase. Lipoprotein lipase enzyme. When this is defective, decrease activity of lipoprotein lipase, or ApoC2 defect, decrease activity of lipoprotein lipase or ApoC2 defect. When there is decreased activity of lipoprotein lipase or ApoC2 defect, it causes the type 1 hyperlipoproteinemia, that is familial chylomicronemia, hyperchylomicronemia, type 1 hyperlipidemia, or the familial hyperchylomicronemia. Decreased lipoprotein lipase activity or ApoC2 defect. This can be MCQ. Type 1 hyperlipidemia or hyperlipoproteinemia. There is increase in the chylomicron level, so that gives lipemic plasma. Chylomicron carries the dietary triacyl glycerol. There is increase in the Tg level, which can be in the thousands. So that causes eruptive xanthomas, the skin lesions, yellowish skin lesions are there, and the pancreatitis. Increased Tg increases the risk of pancreatitis. This is type 1. And what happens in the type 2? In the type 2A, that is LDL receptor defect or ApoB100 defect. So this is LDL receptor defect or ApoB100 defect. Because of defect in this LDL receptor or ApoB100, there is increase in the LDL cholesterol. There is increase in the cholesterol level. There is LDL carries cholesterol, so there is increase in the cholesterol level. There is tendon xanthomas, means that causes the xanthomas on the tendon. So tendon xanthomas are there. And apart from this, there is increase in the cholesterol and LDL cholesterol level, so there is risk of coronary artery diseases, atherosclerosis. Coronary artery diseases, there is risk of atherosclerosis. So this is type 2A, that is type 2A, familial hypercholesterolemia. Familial hypercholesterolemia. So these two disorders, they are very, very important for your university examination. So this is done with the enzyme topic, this is done with the carbohydrate chemistry and metabolism, this is done with the lipid chemistry and metabolism. Now next is the protein chemistry and metabolism, and these are the important disorders related with protein chemistry and metabolism. Related with the plasma protein and electrophoresis pattern, it is multiple myeloma, nephrotic syndrome and cirrhosis of liver. Then related with the protein metabolism, PKU, phenylketonuria, alkaptonuria, maple syrup disease, urine disease, urea cycle disorders, homocystinuria and albinism. These are the very, very important clinical cases. So these are very important clinical cases, and these are rare one: pheochromocytoma, carcinoid syndrome, Hartnupp's disease and Parkinson's disease. So these are the rare clinical cases, but these are the important, very, very important clinical cases. Of these all clinical cases, they are very, very important, very, very important from the uh, protein metabolism topic. Okay. Now in multiple myeloma, there is characteristic M band in the electrophoresis, The single type of immunoglobulins they are produced. Multiple myeloma is the multiple punched out lesion on the bones characterized by excretion of Benzone proteins in the urine, which is detected by the classical heat test. These proteins, Benzone proteins, they are detected in the temperature 40 to 60 degrees centigrade. Of temperature, if the temperature is above the 60 degree, then this coagulum disappears and it reappears on the cooling the solution. That is classical heat test in the multiple myeloma. Excretion of light chain proteins in the urine, that is Benzone proteins, and the M band, characteristic M band in the electrophoresis. Nephrotic syndrome, there is prominent alpha 2 globulins, raised alpha 2 globulin because of alpha 2 macroglobulin larger size. This is retention of alpha 2 macroglobulin, and to some extent beta globulins, they are retained, means their level increases, and all other proteins they lost in the nephrotic syndrome. There is decrease albumin and prominent alpha 2 band, decrease albumin and prominent alpha 2 band indicates the nephrotic syndrome. In the cirrhosis of liver, as the albumin is the site for the liver synthesis of albumin, there is decrease in the albumin level. There is decrease in the albumin level and increase in the gamma globulin section occurs in the cirrhosis of liver. Also, beta gamma bridging can be there in the cirrhosis of liver. So this based on the electrophoretic pattern. In multiple myeloma, prominent M band, nephrotic syndrome, decreased albumin and prominent alpha 2 globulin, cirrhosis of liver, decreased albumin and increased gamma globulin, or beta gamma bridging may be occur in the cirrhosis of liver. Now, these are the important clinical cases. Phenylketonuria because of defect in the enzyme phenylalanine hydroxylase. Here, the phenylalanine hydroxylase is defective. So, phenylalanine is not converted into tyrosine, that is para-hydroxy phenylalanine. This reaction is blocked in this PKU, phenylketonuria. So, it is phenylalanine hydroxylase. This is PKU, phenylketonuria. So, phenylalanine hydroxylase enzyme, it is defective hydroxylase. So, as this is defective, phenylalanine is diverted for production of phenylpyruvate. This is keto acid, that's why the name is given phenylketonuria. It is converted into acetate, which gives mousy odor to the urine. Mousy odor to the urine because of phenylacetate and other byproduct. So this phenylacetate is converted into phenylacetylglutamine. This phenylpyruvate is converted into phenylactate. So these are the different products which are produced because of this defect, phenylalanine hydroxylase. This is known as classical phenylketonuria. It is characterized by mousy odor of urine. And as phenylalanine and tyrosine, this tyrosine in their metabolism, it gives different specialized product. For example, tyrosine gives melanin in skin, hair and eyes. It gives the dopamine in the central nervous system. It gives epinephrine, norepinephrine in the adrenal medulla, and it gives the thyroid hormone T3 and T4 in the thyroid gland. So these are the specialized product given by the tyrosine. So there is neurological symptoms, mental retardation because of decreased synthesis of dopamine, epinephrine and norepinephrine. Then there is hypopigmented patches all over the body because of decreased melanin synthesis. So these are the prominent symptoms in the phenylketonuria. The diagnosis screening test is the Guthrie test, while the confirmatory test is tandem mass spectrometry or GCMS, gas chromatography mass spectrometry combination is used for the diagnosis of phenylketonuria. Here treatment is restrict the phenylalanine in diet. As phenylalanine is restricted, tyrosine becomes essential. Provide the tyrosine in the diet. Behavioral therapy supportive treatment is needed for the treatment of phenylketonuria. So this is very, very important clinical case, phenylketonuria. Now see alkaptonuria, there is black urine. Alkaptonuria, it is black urine turn dark on standing, black urine, and there is tendency to develop arthritis in the latter ages in the patient with alkaptonuria. Black urine and tendency to develop arthritis in the latter ages. There is because of block in the enzyme homogentisate oxidase. So This homogentisate, it is converted into by the polyphenol oxidase, it is converted into the alkaptone pigment, and alkaptone pigment deposition in the cartilage. Various cartilage give black staining of that particular tissues, and there is urine on exposure to air gives the black color in the alkaptone urea. In the alkaptone urea. So this is this phenylalanine tyrosine metabolism defect, that is phenylketonuria, alkaptonuria, and albinism. Albinism, there is defect in the tyrosinase activity. So tyrosinase enzyme is defective, tyrosinase activity. So there is decreased melanin synthesis and generalized hypopigmentation. Along with generalized hypopigmentation, there is photophobia. So that causes the movement of photophobia. So there is nystagmus in the albinism. Hypopigmented means the generalized hypopigmentation because of decrease in the tyrosinase activity. It is here the tyrosinase is the only enzyme which is involved in the melanin synthesis, which is affected in the albinism. In maple syrup urine disease, maple syrup urine disease, it is related with metabolism of valine, isoleucine, and leucine. It is because of defect in the enzyme branch chain ketoacid dehydrogenase. Branch chain ketoacid dehydrogenase. We'll discuss this wet. Maple syrup urine disease. It is related with metabolism of valine, isoleucine, and leucine. All of you know that leucine is the ketogenic amino acid. It will give fat. Isoleucine will give both glucose and fat, and valine will only give the glucose. This amino acid on transamination, it is converted into alpha keto acids. This is branch chain amino acid metabolism. These amino acids on transamination by the transaminase, that is PLP dependent transaminase, it is converted into alpha keto acid, and by alpha keto acid dehydrogenase. So that is branch chain alpha keto acid dehydrogenase enzyme. It is converted into respective acyl coenzyme A, and this acyl coenzyme A then will converted into glucose, then we do converted into glucose, and fat will converted into only fat. Okay, this respective acyl coenzyme A, they are converted into glucose and fat depending upon whether this is glucogenic or ketogenic amino acid. Now when there is defect in branch chain alpha keto acid dehydrogenase enzyme, it causes maple syrup urine disease, which is characterized by there is increased formation of alpha keto acids, and their excretion in the urine give the maple syrup like smell of the urine. Maple syrup like syrup or burnt sugar smell, burnt sugar smell of the urine. Also there is acidosis, also there is acidosis in the maple syrup urine disease. So there is a period of hypertonicity and flaccidity that gives the boxing and bicycling like posture in the maple syrup urine disease. There is smell of burnt sugar. So there is intellectual disability, brain is affected, mental retardation is there in the maple syrup urine disease. So this is very important related with the branch chain amino acid metabolism. Okay. Then urea cycle disorders, all of you know that 5 enzymes are there in the urea cycle. So first 2 enzyme, there is hyperammonemia, the severe hyperammonemia is there. There is increased ammonia level, and depending upon the level of block, the enzyme which is blocked, there is severity of this hyperammonemia. So in first 2 disorders, uh, that is hyperammonemia type 1 and type 2, there is severe hyperammonemia, and that causes the CNS manifestation because it diverts or depletes the alpha ketoglutarate level, hampers the TCA cycle, decrease in the ATP synthesis occurs. That's why this ammonia is toxic to the brain. It depletes the alpha ketoglutarate level. So urea cycle disorders, depending upon the block, there are 5 disorder and 1 syndrome, that is triple H syndrome, that is known as hyperornithinemia. Okay, so this is also important. So there is, if there is increased NH3 level, think about the hyperammonemia and the urea cycle disorders. Then homocystinuria, again important disorder in which there is subluxation of lens occur. We'll discuss this homocystinuria. See, homocystinuria. Now, in homocystinuria, there is defect in the enzyme cystathionein beta synthase. Now, see, this is metabolism of methionine, where methionine, see, methionine is converted into S-adenosyl methionine. Then S-adenosyl methionine is converted into S-adenosyl homocysteine. which is converted into homocysteine, and homocysteine is converted into methionine. This is methionine metabolism. This homocysteine combines with the serine to form cystathionine, and by the cystathioninase it is converted into cysteine plus homoserine. So this is metabolism of sulfur containing amino acid methionine and cysteine. Methionine and cysteine. Now homocysteine plus serine from cystathionine, and cystathionine by the cystathioninase it gives the cysteine. Now here when there is block in this enzyme, that is cystathionine beta synthase, thionine beta synthase, it causes homocystinuria. Homocystinuria. In this disorder, there is increased homocysteine level, there is increased methionine level, and there is decreased cysteine level. So cysteine is given in the treatment. Cysteine is given in the treatment, restrict the homocysteine, restrict the methionine level. This homocystinuria, this homocysteine causes the serious abnormality. So serious problem will be there in the homocystinuria because of elevated homocysteine level. There is cyanide nitroprusside test is positive in the homocystinuria, and there is subluxation of lens, that is known as ectopia lentis. Subluxation of lens occurs, that is inferonasal subluxation of lens occur, that is known as ectopia lentis. Ectopia lentis. Subluxation of lens, dislocation, partial dislocation of lens means subluxation of lens. So subluxation of lens, myopia, cerebrovascular disorders, and the cyanide nitroprusside test is positive in the homocystinuria because of cystathionine beta synthase defect. Pyridoxal phosphate dependent enzyme can respond to the pyridoxal phosphate therapy, also respond to the cysteine therapy. This is homocystinuria. Then pheochromocytoma, there is increase, this is adrenal gland tumor in which there is headache, palpitation, raised blood pressure occurs, and there is increased excretion of vanillyl mandelic acid in the urine, and also there is increased excretion of epinephrine metabolites. Epinephrine, non-epinephrine level increased excretion of vanillyl mandelic acid in the urine. There is headache, increased blood pressure, palpitation. These are the features of pheochromocytoma, adrenal gland tumor. Carcinoid syndrome, it is a tumor of argentapin cell of the intestine where more than 60% tryptophan it is converted into serotonin, and this elevated serotonin causes the symptom in terms of flushing, diarrhea, facial flushing, diarrhea, the increased heart rate. These are the symptoms because of serotonin, because it is a cerebral excitator. So it is tumor of argentapin cell of the intestine. Then heart nerve disease, it is defect in the absorption of tryptophan from intestine and renal tubules. Intestine and renal tubules, defective absorption of tryptophan occurs in heart nerve disease. There is ataxia in the heart nerve disease. There is ataxia means loss of coordination. There is mental retardation. Blue staining of diaper can occur in the heart nerve disease. So mental retardation, ataxia, and pellagra like symptoms because tryptophan is converted into niacin. So niacin production is decreased in the heart nerve disease. So pellagra like symptoms, that is diarrhea, dementia, and dermatitis may be there in the heart nerve disease. So this is the important one. The Parkinson's disease, it is because of the degeneration of certain parts of the brain, that is substantia nigra and locus coeruleus of the brain. The degeneration occurs, so there is decreased dopamine level. That gives the typical feature, that is mask like face, tremor, rigidity, involuntary movements. These are the features of the Parkinson's disease because of decreased dopamine level. Age related problem, near about 1% population above the age of 60 years is affected with the Parkinson's disease. The L-DOPA along with the carbidopa is given in the treatment of Parkinson's disease. So these are the important clinical cases related with the protein metabolism, and these are the must read cases from the protein metabolism. Phenylketonuria, mousy odor of urine. Alkaptonuria, urine turn black on standing. Maple syrup urine disease, smell of maple syrup or burnt sugar of the urine. Urea cycle disorder, there is hyperammonemia. Homocystinuria, there is subluxation of lens. Cyanide nitroprusside test is positive. Increased homocysteine level that causes serious abnormalities. Albinism, generalized hypopigmentation. Nystagmus, photophobia is there. Albinism. Supportive care is needed. Protection from sunlight is needed in the albinism. Multiple myeloma, M-band, nephrotic syndrome, raised alpha 2 fraction in the electrophoresis, decreased albumin level, cirrhosis of liver, decreased albumin level, and beta gamma bridging may be occurs in there. Pheochromocytoma, high blood pressure, headache, palpitation, these are the symptoms. Adrenal gland tumor, increased excretion of vanillyl mandelic acid in the urine. Carcinoid syndrome, tumor of the argentapin cells of the intestine. So more 60% of tryptophan is diverted for the serotonin production by the in the intestinal cell. So serotonin causes the symptoms in terms of diarrhea, flushing, facial flushing, diarrhea, high heart rate. These are the symptoms. High BP. These are the symptoms of carcinoid syndrome. Heart nerves disease. There is mental retardation. Mental retardation, heart nerves disease. There is decreased absorption of tryptophan from intestine and renal tubules. And as the niacin formation hampers, there is pellagra like symptoms in the heart nerves disease. So mental retardation, ataxia, and the pellagra like symptoms in the heart nerves disease. Parkinson's disease, decreased dopamine, age related decrease in the dopamine level that causes the mask like face, rigidity, tremor, involuntary movements. So these are the characteristic clinical cases having the features, means key features for the diagnosis. So these are the related with the protein metabolism. Now nucleic acid metabolism, nucleic acid chemistry and metabolism. Gout is very important clinical case. Gout. So increase uric acid level in the gout. Increase uric acid level. The most common site is first metatarsophalangeal joint is affected. Great toe. Great toe is affected. So there are primary causes and secondary causes of the gout, in which there is the it affects the nucleotide metabolism, purine nucleotide synthesis and degradation. It is affected, and that causes the gout. First metatarsophalangeal joint is affected. The monosodium crystal deposits in the joint. What is a gold standard test or confirmatory test for the diagnosis of the gout? It is aspiration and the microscopy. Negatively birefringent urate crystals in the microscopy is a gold standard test for the diagnosis of the gout. Uric acid can be a screening test for the gout. Screening test. Okay. For increased uric acid level, 3 to 7 milligram per deciliter is normal range of uric acid in the male, and 2 to 5 milligram per deciliter in the female. So increased uric acid production causes the gout. Allopurinol is the drug which is given in the treatment of the gout. Allopurinol. Okay, so there is increased activity of PRPP synthetase, increased activity of glutamyl amidotransferase enzyme, decreased activity of glucose 6 phosphatase, that is in von Gog's disease. Then decrease HGPRTase level, that is Leishman syndrome, and the increased activity of glutathione reductase enzyme causes the, these are the causes of primary gout. And secondary causes that includes the leukemia, cancer chemotherapy, psoriasis, that can be causes of the secondary gout. Increased uric acid level causes the pain in the joints. The first metatarsophalangeal joint is affected. Allopurinol by competitive and suicide inhibition, this is a drug of choice for the treatment of the gout. Now the Leishman syndrome, this is X-linked disease, affect the male child, and there is purine nucleotide salvage, means purine salvage pathway, it is affected here. Purine salvage pathway. Purine salvage pathway, it is a direct synthesis of nucleotide. Purine salvage pathway, there is synthesis of nucleotides. For example, adenine is converted into AMP, guanine is converted into GMP, and the hypoxanthine is converted into inosine monophosphate. So this required hypoxanthine guanine phosphoribosyl transferase enzyme, HGPRTase enzyme, and if defect in this enzyme HGPRTase, it causes the purine salvage pathway, direct synthesis of nucleotide from the nitrogen base. This is important in the brain and RBCs. So brain and RBCs, they are dependent on purine salvage pathway. Decreased production of nucleotide in the brain causes this Lesch-Nyhan syndrome. Typical feature, self mutilating activity, excessive नाखून खाना, खून निकलने तक नाखून खाना. So head banging, self mutilating activity, that is the nail biting. Then lips injury, self injury to the lips may be there. These are the features of the Lesch-Nyhan syndrome, along with increased uric acid level. Increased uric acid level, these are the features of Lesch-Nyhan syndrome. Okay, orotic aciduria, it is a disease related with the pyrimidine nucleotide synthesis. Pyrimidine nucleotide synthesis, there is orotate excretion in the urine, orotic acid excreted in the urine, and there is megaloblastic anemia as the thymidylate synthase, megaloblastic anemia, because of decreased nucleotide synthesis that hampers the DNA synthesis. That's why there is megaloblastic anemia and orotate excretion in the urine. This is because of defect in the pyrimidine nucleotide synthesis pathway, that is two enzymes, that is O2, OMP decarboxylase and OPRTase. These two enzymes are defective in the orotic aciduria. OMP decarboxylase and OPRTase, orotate phosphoribosyl transferase. Then severe combined immunodeficiency, this is disease in which there is decreased uric acid level occurs. B cell and T cell both are affected in the severe combined immunodeficiency. There is decreased activity of adenosine deaminase. Adenosine deaminase, this is defective, this enzyme is defective, and there is severe combined immunodeficiency. Both T cell and B cell functions affected, that causes recurrent infection, and there is decreased uric acid level in the severe combined immunodeficiency. This is also connected with the this is connected with the DNA repair mechanism. When there is double strand break repair, when there is fault in the double strand break repair, that is non-homologous end joining, that causes the severe combined immunodeficiency. So these are the four important cases. First two are very, very important clinical cases from the nucleotide chemistry and metabolism. Now see, from the hemoglobin, hemoglobin is all about the clinical cases: sickle cell anemia, thalassemia, neonatal jaundice, porphyrias, that is acute intermittent porphyria, congenital erythropoietic porphyria, and porphyria cutanea tarda. These are the important clinical cases. Porphyria, and three types of jaundice: hemolytic, hepatic, obstructive. So hepatic and obstructive we already discussed in the enzyme topic. So this is connecting link between the liver function test, hemoglobin topic, and the enzyme topic, this jaundice. So this is very, very important, remember this. Now sickle cell anemia, all of you know that sickle shape RBC that occludes the blood vessel, sickled RBC that occludes the blood vessels because of mutation, partially acceptable missense point mutation is there, and because of this hemoglobin S will form. This hemoglobin S in deoxygenated form, it polymerizes and forms the aggregates, and this fiber distort the shape of the RBC into sickle shape, and this sickle shape RBC block the microvasculature, they do not move freely. So they block the vasculature, and distal to that part, that organ is affected and damaged, so that causes the pain. Tissue hypoxia, that causes the damage and pain of that the damaged tissue, that causes the pain. So pain in the extremities, anemia, and jaundice, these are the features of sickle cell anemia. Pain in the extremities, anemia, and jaundice. Because of rapid hemolysis, there is breakdown of heme, it is converted into bilirubin, there is increase in the bilirubin level. So hemolytic jaundice is there in the sickle cell anemia. Partially acceptable missense point mutation, that's why in place of hemoglobin A there is hemoglobin S. Hemoglobin S in the polymerization form or deoxyhemoglobin form, when there is oxygen is low, it forms the fiber that distort the shape of the RBC into the sickled shape that occludes the blood vessel. So this is important in the sickle cell anemia. It is hemoglobinopathy. While thalassemia is the decreased quantity of hemoglobin, particularly alpha or beta globin chain. If there is decrease in the alpha globin chain, it causes the alpha thalassemia. If there is decrease in the beta globin chain, there is beta thalassemia. Beta thalassemia major means the homozygous state where both the genes are affected. It is important clinical case. In the beta thalassemia major, there is decreased beta or no beta is there. As no beta is there in the beta thalassemia major, so there is no beta no beta. So there is no low, very low or no hemoglobin A. Hemoglobin A is alpha 2, beta 2. So very low hemoglobin A or no hemoglobin A, there is increase in the hemoglobin F, fetal hemoglobin, which is alpha 2 gamma 2, and there is increase in the hemoglobin A2, that is alpha 2 delta 2. So hemoglobin F, hemoglobin A2 increases, hemoglobin low A levels are very low. So because of extramedullary hematopoiesis, there is hepatosplenomegaly, hepatosplenomegaly. The thalassemic phases, that is frontal bossing maxillary overgrowth is there in the beta thalassemia major. Hepatosplenomegaly, frontal bossing maxillary overgrowth, and hair on end appearance on the X-ray skull is the diagnosis for it helps in the diagnosis of beta thalassemia major. Mainly beta thalassemia major, you may get a case of beta thalassemia major. So low hemoglobin A or no hemoglobin A, increased hemoglobin F and hemoglobin A2, hepatosplenomegaly, frontal phases, frontal bossing, and the maxillary overgrowth, and the anemia and jaundice, hemolytic anemia and jaundice. So there is anemia, means decreased hemoglobin, there is jaundice, increased bilirubin level in the thalassemia. So neonatal jaundice, it is again important, very very important clinical case, neonatal jaundice. Neonatal jaundice, the jaundice appears on second or third day of life, and there is increase in the unconjugated bilirubin. Unconjugated bilirubin increases in the neonatal physiological jaundice. This is known as physiological jaundice. Bilirubin can go up to 11, 12, 13, 14. The bilirubin, unconjugated bilirubin can go up to this. And phototherapy, a blue light therapy is given which converts the unconjugated bilirubin into a soluble, water soluble, excretable form of the bilirubin, and it is excreted in the urine. Phototherapy is given in neonatal physiological jaundice. This is very very important clinical case. This is because of inability of immature liver of the neonate, rapid hemolysis of the RBCs in the neonate, and immature liver to for uptake and conjugation of bilirubin jaundice. It is pathological when it is within 24 hours, which is mainly because of RH incompatibility or ABO incompatibility. In porphyria, there is three porphyrias which are important. All porphyrias, they are autosomal dominant except congenital erythropoietic porphyria, X-linked sideroblastic anemia, and the protoporphyria. All other are autosomal dominant. In acute intermittent porphyria, there is uroporphyrinogen 1 synthase which is defective. In congenital erythropoietic porphyria, uroporphyrinogen 3 co-synthase is defective, and porphyria cutanea tarda, uroporphyrinogen decarboxylase is defective. So these are the enzymes which are defective in this clinical condition. Now acute intermittent porphyria, abdominal pain and neurological manifestations, they are symptoms, and there is increased level of ALA and PBG. So in acute intermittent porphyria, see, in acute intermittent porphyria, there is two main symptoms, that is abdominal pain and neuropsychiatric symptoms. Neuropsychiatric manifestations are there in the acute intermittent porphyria, and increase ALA, aminolevulinic acid, and increase parfobilinogen in the urine can be diagnostic test for the acute intermittent porphyria. The pain is vague and intermittent, abdominal pain and neurological manifestations are there. There is no photosensitivity in the acute intermittent porphyria. In the congenital erythropoietic porphyria, it is also known as Gunther's disease. There is only photosensitivity. Because of sensitivity because of formation of porphyrin precursor. So there is porphyrin formation which is excited. Porphyrins, they are excited, they produce reactive oxygen species, they causes the damage to the lysosomes, and lysosomal enzymes causes the skin lesions, that is known as photosensitivity in congenital erythropoietic porphyria. Also there is erythrodontia, means the red teeth, erythrodontia on wood lamp examination, Also red urine on wood lamp examination is there. Red urine, erythrodontia, and the photosensitivity. These are the features of congenital erythropoietic porphyria. And porphyria cutanea tarda, this is most common porphyria. This is blistering skin lesions, means photosensitivity are there. Blistering skin lesions are there in the porphyria cutanea tarda. Blistering skin lesion. This is because of uroporphyrinogen 1 synthase, also known as parfobilinogen deaminase or the hydroxymethylbilin synthase defect. This is because of uroporphyrinogen 3 co-synthase defect. Co-synthase defect. Congenital erythropoietic porphyria, it is autosomal recessive, and this is because of uroporphyrinogen decarboxylase defect. Decarboxylase defect. When there is ALA and PBG in the urine, it is acute intermittent porphyria. When there is only photosensitivity, red urine or erythrodontia, it is, and the small skin lesions, this is congenital erythropoietic porphyria. When there are blistering bullous skin lesions are there, it is porphyria cutanea tarda. So this is porphyrias. And the jaundice, we already discussed the jaundice, three various types of jaundice: hemolytic, hepatic, and obstructive jaundice. In hemolytic jaundice, there is absent urinary pigment, bile pigment, means bilirubin. Means there is this in hemolytic jaundice there is negative. Fauchet test is negative in the hemolytic jaundice for the bile pigment, and the Hayes sulfur test is also negative. These both tests are negative in the hemolytic jaundice. These both tests are negative. This test is positive in obstructive jaundice and can be positive in the hepatic jaundice. Fauchet test and Hayes test. In hemolytic jaundice, unconjugated bilirubin, indirect bilirubin increases, while here in hepatic jaundice, both type of bilirubin increases. Here in obstructive, direct bilirubin increases. In obstructive jaundice, there is raised alkaline phosphatase activity. Hepatic jaundice, there is raised SGOT, SGPT level, and hemolytic jaundice, there is, these enzymes are normal. These enzymes are normal in the hemolytic jaundice. So these are the different clinical cases from the hemoglobin topic. Now these are the simple cases from the vitamin and minerals. Night blindness, xerophthalmia, Bitot spot, corneal degeneration, corneal ulcer. The increase in the dark adaptation time, it is due to vitamin A deficiency. Rickets and osteomalacia, it is due to vitamin D deficiency. Scurvy, it is due to vitamin C deficiency. What are the symptoms, deficiency manifestations of vitamin A? 600 microgram is the RDA. Richest source, it is cod liver oil, fish liver oil, halibut liver oil, and the polar bear liver. These are the rich sources of the vitamin A. And the beta carotene, it is present in the carrots, orange, yellow, orange color fruits and green leafy vegetable. Beta carotene is present, which is having the antioxidant function. Retinol, it is a form which is required for the vision. Rhodopsin, in which 11-cis retinol is there. Retinol aldehyde form is important, which is important for the vision. Retinoic acid, it is for the growth and differentiation. Retinol is for the maintenance of epithelium and the skin, which is important. Retinol, and beta carotene is the antioxidant. So vitamin A deficiency causes the increase in the dark adaptation time, then the night blindness, Bitot spot, triangular white opaque spot on the conjunctiva, Bitot spot. Then it causes the corneal xerosis, then corneal ulceration, and the keratomalacia. So blindness, world most common cause of preventable blindness, vitamin A deficiency. Then rickets, it is in the children, and it causes the spongy bone, as vitamin D is required for the formation or mineralization of bone. The deficiency causes the spongy bone. So जो जब वो crawl करने लगता बच्चा, So it is the widening of the wrist occurs, and जब वो चलने लगता because of the weight bearing bones, weight bearing bones, they bowed because of spongy, because of the sponginess, because of the decreased mineralization. Also other features are also there, that is craniotibis ping pong ball like skull, then the prominent costochondral junction that is known as rachitic rosary, Harrison sulcus, which is a transverse groove across the insertion of diaphragm. These are the symptoms in the rickets. Also, there is increase in the alkaline phosphatase activity. In osteomalacia, there is frequent bone fracture because of decreased bone mineral density. There is osteoporosis and increase in the alkaline phosphatase level. Frequent fractures may be the presenting complaint in the osteomalacia. Vitamin D deficiency in the adult causes osteomalacia. In the children, it causes the rickets. Scurvy, the bleeding gums and the loose teeth, bleeding gums, loose teeth, petechial hemorrhages, hemorrhagic spots on the skin, then the hemorrhage in the joint causes the pseudo paralysis or pseudo arthritis, pseudo paralysis. Scurvy, there is prominent costochondral junction in the scurvy that is known as rachitic rosary. Vitamin C is required. Vitamin C, it is required for the hydroxylation of proline and proline and lysine. Hydroxylation of proline and lysine, vitamin C is required. It is important for the collagen synthesis. Collagen is the important in the structure of blood vessels. Defective collagen synthesis causes brittle blood vessels that can easily rupture. So that's why bleeding gums, loose teeth, and the hemorrhagic tendencies from reddish spot on the skin because of brittle blood vessel, easily fragile blood vessel because of defective collagen synthesis because of vitamin C deficiency. It is required for the hydroxylation. Vitamin C is required for the hydroxylation of proline and lysine. So it is important in the collagen synthesis. So vitamin A deficiency causes the blindness, vision, it affects the vision. Vitamin D deficiency causes rickets and osteomalacia. Vitamin C deficiency causes the scurvy. Beriberi. There are three types of beriberi: dry beriberi, wet beriberi, and infantile beriberi. Thymine pyrophosphate. Thymine pyrophosphate is the active form of the thymine. Thymine is present in outer layer of the whole grains. So polishing removes the thymine, and polishing means when we consume rice, polished rice as a staple diet, it causes the beriberi, dry, wet, and infantile beriberi. Now remember, dry beriberi, there is neuritis, peripheral neuropathy. Wet beriberi, there is high output cardiac failure. High output cardiac failure because of marked peripheral vasodilation in the thymine pyrophosphate deficiency. Thymine is required for the nerve conduction. It phosphorylates and activates the chloride channels. That's why it is important for the nerve conduction. So dry beriberi, wet beriberi, and when it is the severe manifestation in the infant due to deficiency of thymine in the pregnancy, it causes the infantile beriberi. Dry, wet, and infantile beriberi. Also thymine deficiency in the chronic alcoholic. In the chronic alcoholic, it causes the symptoms, typical symptoms. Pneumonic is Goa MP. Pneumonic is Goa MP. It causes Wernicke's encephalopathy and Korsakoff psychosis. Chronic thymine deficiency in the alcoholic, because alcohol prevent the conversion of thymine to thymine pyrophosphate and prevent the absorption of thymine from the GIT. That's why there is Wernicke's encephalopathy and Korsakoff psychosis. These are the symptoms. Global confusion, ophthalmoplegia means paralysis of ocular muscle, ataxia means lack of coordination, memory loss and psychosis. मेमोरी लॉस एंड साइकोसिस, इतना याद रखो। गजनी मूवी में आमिर खान को बंद करके रखता तो उसको थायमिन डिफिशियंसी होती। कैसा बिहेव करता वो, कैसे बिहेव करता? ग्लोबल कंफ्यूजन, ऑप्थेल्मोप्लेजिया, पैरालिसिस ऑफ ऑकुलर मसल, अटैक्सिया, लैक ऑफ कोऑर्डिनेशन, मेमोरी लॉस डिफिकल्टी, शॉर्ट टर्म मेमोरी लॉस रहता है ना उसको, मेमोरी लॉस एंड साइकोसिस। क्रोनिक अल्कोहलिज्म कॉजेज द दिस वर्निकेस कोर्सैकॉफ सिंड्रोम। उसमें वो पीता नहीं, लेकिन याद रखो वो सिम्टम्स, वर्निकेस कोर्सैकॉफ सिंड्रोम। गोवा एमपी, ग्लोबल कंफ्यूजन, ऑप्थेल्मोप्लेजिया, अटैक्सिया, मेमोरी लॉस, साइकोसिस। These are the symptoms because of thymine pyrophosphate deficiency. Now riboflavinosis, this is vitamin that is B2, riboflavin deficiency. It causes, deficiency causes cheilosis, glossitis, angular stomatitis, Then sir, all are circumoral manifestation. Then conjunctivitis and seborrheic dermatitis. These are the manifestations of B2 deficiency. Diarrhea, dementia, dermatitis, pellagra. Diarrhea, dementia, and dermatitis. These are the features of pellagra. That is Castle's necklace dermatitis. Dermatitis. Castle's necklace. Necklace shaped dermatitis around the neck, glove and stalking appearance of hand and feet, sun exposed part of the body, it is involved in the pellagra. Decrease niacin, B3. Decrease niacin causes pellagra. Niacin is also formed from the tryptophan. So, the tryptophan metabolism disorders, for example, heart nerve disease, carcinoid syndrome, pyridoxal phosphate deficiency, and the jawar and maize in the diet that causes the pellagra. Niacin deficiency. These are the classical 3Ds. If untreated, causes the death. Megaloblastic anemia can be due to B12 deficiency, can be due to folic acid deficiency. So B12 and folic acid, they are required for the nucleotide synthesis, they are required for the DNA and RNA synthesis. In the absence of this or deficiency of this B12 and folic acid, there is defective nucleotide synthesis, defective DNA, smaller size of the nucleus, cell cycle, it is arrested in the S phase of cell division, and cell grows continuously without cell division. So larger cytoplasm, small nucleus. So megaloblastic RBCs are there in the folate deficiency. B12 and folate, they are connected by the methionine synthase reaction. So that is in B12 deficiency, there is also folate deficiency. That's why there is the megaloblastic anemia. So B12, the dietary sources, they are predominantly the animal origin, food of animal origin, and folium means leaves, folic acid present in the leaves. B12 absorption occurs, iron, folic acid, B12, it is from the ileum, folic acid, it is from the jejunum. So iron, folic acid, B12, iron from the duodenum, folic acid from the jejunum, and the B12 from the ileum. See, it is like this: iron, folic acid, B12, duodenum, jejunum, ileum. Duodenum, jejunum, ileum. Site of absorption. Requirement of B12 is 1 to 2 microgram per day. Folic acid requirement is 200 microgram per day. In pregnancy, it is 500 microgram per day. Folic acid deficiency causes the neural tube defect, that is spina bifida and anencephaly. In pregnancy, if it is less, it causes the defect in the neonate, that is spina bifida and anencephaly, that is known as neural tube defect. So these are the important clinical cases. Once again, xerophthalmia and the vision related problem, it is because of vitamin A deficiency. Rickets osteomalacia, it is vitamin D deficiency. Scurvy, vitamin C deficiency. The dose RD of vitamin C is 60 to 75 milligram per day. Beriberi, it is thiamine pyrophosphate deficiency. Riboflavinosis, circumoral and circumcorneal manifestations are there in the B2 deficiency. Diarrhea, dementia, dermatitis in niacin deficiency, megaloblastic anemia, B12 and folic acid deficiency. If it is because of B12 deficiency, along with this megaloblastic anemia, there is methylmalonic aciduria. Methylmalonic aciduria. Also, there can be a subacute combined degeneration of spinal cord in the B12 deficiency. But in folate deficiency, there is megaloblastic anemia, and on histidine load test, there is excretion of farm-iminoglutamic acid, that is FIGLU, farm-iminoglutamic acid excretion occurs in the folic acid deficiency. And Wernicke-Korsakoff syndrome, it is because of thiamine pyrophosphate deficiency, chronic deficiency of thiamine pyrophosphate in alcoholic. So these are the different clinical conditions in the vitamin deficiency. Now mineral deficiency, these are the important clinical cases from the mineral. Tetany, it is related with the calcium. Iron deficiency anemia, iron. Wilson's disease, Menkes disease related with the copper. Acrodermatitis enteropathica related with the zinc. Fluorosis, it is excess of the fluoride. And iodine deficiency means decrease iodine level. So it affect the synthesis of T3 and T4. Iodine deficiency, goiter. So these are the clinical cases related with the minerals. Now say tetany, it is carpopedal spasm. It is medical emergency. Carpopedal spasm. Deficiency of calcium, when calcium goes below 6 milligram per deciliter, 7 or 6 milligram per deciliter. This is the typical position of hand in the tetany. There is flexion of the wrist joint. There is flexion of the wrist joint. There is extension of metacarpophalangeal joint, extension of metacarpophalangeal joint, and extension of interphalangeal joints. So this is flexion of metacarpophalangeal joint and extension of the fingers. This is the position of the hand that is known as the carpopedal spasm. Treated by the calcium gluconate 10%, 10 ml calcium gluconate over the period of 10 minute IV, followed by the maintenance drip. Tetany, it is not tetanus, carpopedal spasm. So what are the symptoms of calcium deficiency? It is CATS, that is convulsion, arrhythmia, tetany, tremor, stridor or spasm. These are the symptoms of calcium deficiency. Iron deficiency anemia. In iron deficiency anemia, there is decrease in the hemoglobin level, decrease in the MCV, mean corpuscular volume. This is iron deficiency anemia. It causes microcytic hypochromic anemia. There is increase in the total iron binding capacity. Total iron binding capacity, decrease in the ferritin level, decrease in the ferritin level. These are the laboratory parameters and the iron deficiency anemia. Chylonychia, spoon shaped nail, pallor is there, decrease interest in the surrounding, sluggishness, weakness. These are the symptoms of iron deficiency anemia, and these are the laboratory parameter: decrease hemoglobin, decrease mean corpuscular volume, increase total iron binding capacity, decrease in the ferritin level. These are the laboratory picture in the iron deficiency anemia. So 10 to 20 milligram per day is the RD of iron. It is present in the green leafy vegetables. Also it is present in the meat, fish, but it is mainly present in the green leafy vegetable, and it is having the important functions because there are many proteins which contain the iron. For example, hemoglobin, myoglobin, cytochrome, some enzymes, tryptophan, pyrrolase, nitric oxide synthase, catalase, they contain the iron, and the functions of iron is because of the iron containing proteins. Wilson's disease, here there is excess of the copper occurs, and here Menkes disease there is decreased copper, means decreased level of copper, so that causes the Menkes disease. Wilson's disease, Menkes disease will discuss. See, uh, intestine to liver, and liver to excretion bile, and the incorporation into ceruloplasmin. Now see, decrease absorption, from the intestine, ATP7A protein, ATP binding acid transporter protein. This transporter is defective in Menkes disease. So there is decreased absorption of copper that causes neurodegenerative disorder, that is known as Menkes kinky hair syndrome. Here the steel or wiry hair is there, easily pluckable hair is there in the Menkes disease. So there is involvement of hair. There is hypopigmented patches because of affected tyrosinase activity. Hypopigmented patches and mental retardation, neurodegenerative disorder. Mental retardation is there in the Menkes disease because of mutation in ATP7A. So there is less copper, and the copper dependent enzymes, they are affected, and that causes the symptoms. Here ATP7B is mutated in the Wilson's disease. ATP7B is mutated, and this causes the symptoms. So there is decreased excretion of copper into the bile and decreased incorporation of copper into the ceruloplasmin. So this causes the hepatolenticular degeneration. So there is involvement of brain, there is involvement of liver. Hepatolenticular nucleus of the brain, lenticular nucleus of brain and liver is involved. So diagnostic gold standard test is liver biopsy and quantitative assay of the copper. So here copper excess occurs, and also urinary 24-hour urinary copper measurement is also a screening test for the diagnosis of Wilson's disease. It is hepatolenticular degeneration, copper excess occurs in the Wilson's disease, copper accumulates in the liver, copper accumulates in the brain. There is KF ring, Kaiser-Fleischer ring around the cornea, which is a golden ring around the cornea. So that is golden color ring around the cornea, that is known as KF ring, Kaiser-Fleischer ring in the decimate membrane of cornea, and in the lens it causes the sunflower cataract. It causes the sunflower cataract. So these are the symptoms of the Wilson's disease. So this is important related with the copper metabolism. Acrodermatitis enteropathica, it is a zinc deficient condition. It is an autosomal recessive disorder in which the acral part of the body is involved, particularly in the infant. There is dermatitis in the zinc deficiency. There is dermatitis. It is DAD, alopecia, and diarrhea. So alopecia, alopecia, dermatitis, DAD. Then delayed wound healing, impaired spermatogenesis, loss of taste sensation. These are the features of the zinc deficiency. Zinc is present in more than 300 enzymes: superoxide dismutase, ALA dehydratase, various dehydrogenase, RNA polymerase, carboxypeptidase. Zinc is present. So these are the dermatitis, alopecia, diarrhea, delayed wound healing, loss of taste sensation, defective spermatogenesis. These are the features of the zinc deficiency. Fluorosis. Fluorosis here, fluoride excess, it is present in the fluoride when it is more than 5 ppm or when it is more than 20 ppm. When it is more than 20 ppm, it causes skeletal fluorosis. So excess of fluoride in the bone, it causes bone deformity. There is the teeth are affected, mottling of enamel is there, the teeth genu vulgum varum deformity is there in the fluorosis. So entire village is affected by the fluorosis, not a single person but entire village, because of high content of fluoride in the water, in the drinking water. In the iodine deficiency anemia, there is goiter, there is enlarged thyroid gland in search of iodine. Thyroid cells enlarge in search of iodine to trap the iodine. So enlargement of iodine, thyroid gland is there. Thyroid iodine is required for the formation of T3 and T4. So in iodine deficiency goiter, there is decrease in the thyroid hormone that causes hypothyroidism. And chronic severe deficiency in pregnancy causes the cretinism in the child. There is mental retardation, precocious puberty, and the high congenital hypothyroidism, that is the cretinism in if it is in the pregnancy. So these are the mineral related clinical cases. Tetany, carpopedal spasm, when the calcium level goes below 7 milligram per deciliter. Iron deficiency anemia, there are various causes of iron deficiency anemia: repeated miscarriage, abortion, uh, uh, the hookworm infection, then the chronic blood loss as it occurs in the repeated pregnancy can cause the iron deficiency anemia. 10 to 20 milligram per day is the required. In the female, it is requirement is more in the pregnancy and in lactation. Wilson's disease, it is because of the copper defect. Copper metabolism is involved here. Wilson's, there is excess of copper. Menkes disease, there is decreased absorption of copper. Acrodermatitis enteropathica, zinc is involved. 10 milligram per day is the requirement of RDA. Zinc is present in the shellfish, nuts, beans, and meat. It is present. Deficiency causes acrodermatitis enteropathica. The features are dermatitis, typically involve the acral part of the body. Finger, nose, toes, mouth, perineal area, it is involved in the acrodermatitis enteropathica. Particularly affect the infant, causes the diarrhea, alopecia, dermatitis. Also, zinc deficiency causes the delayed wound healing, alopecia, decreased taste sensation, impaired spermatogenesis. Fluorosis, it is because of excess fluoride. Chronic fluoride deficiency less than 0.5 ppm for the chronic period, it causes the dental caries. Iodine deficiency goiter is because of iodine deficiency in the soil. In the particularly high altitude, the hilly areas, because iodine content of soil, it is washed with the water. That's why there is low content of iodine in the food. So that causes iodine deficiency goiter. Then these are the miscellaneous topic from this topic: kwashiorkor, marasmus. This is protein energy malnutrition. It is important. Protein energy malnutrition. It is important. Remember, there is edema. There is edema in the kwashiorkor. There is no edema in the marasmus. It is wasting. Marasmus, severe muscle wasting is there in the marasmus. Kwashiorkor, there is edema. Kwashiorkor, there is edema, and this is because of the protein deficiency. This is because of the calorie deficiency. Then in the organ function test, if there is increased creatinine, increased urea, along with the deranged electrolyte levels, it causes, and the clearance, if clearance is decreased, it indicates the acute renal failure. Hypothyroidism means decrease in the T3 and T4, and increase in the TSH level is there in the hypothyroidism. Hyperthyroidism means increase in the T3 and T4 hormone and decrease in the TSH level. So hypo means decrease thyroid hormones, hyper means increase thyroid hormone, and inverse with the TSH. Inverse with the TSH. We already discussed the prehepatic, hepatic, and the post-hepatic jaundice. So these are the topics under the organ function test. These are the topics from the metabolic acidosis, alkalosis. That is, these are the four important case, and diagnosis is very easy. See, this is the pH scale. 7.35 to 7.45 is the normal. If it is below this, it is acidosis. Label the patient as acidosis. And if it is above this, it is alkalosis. This is simple. Acidosis, alkalosis. Don't think any other thing. If pH is low, it is acidosis. If pH is high, it is alkalosis. It is clear. This is primary. Okay. Now see second parameter. See for the partial pressure of CO2. Partial pressure of CO2, 35 to 45 mm of Hg. mmHg is the normal range. If the partial pressure of CO2 means carbonic acid, CO2 means dissolve carbonic acid, dissolved CO2, carbonic acid. So here, if carbonic acid increases means acid increases, and CO2 it is respiratory component. So it is respiratory acidosis. Respiratory acidosis. If carbonic acid increases, it is respiratory acidosis. If carbonic acid decreases means alkalosis. It is respiratory alkalosis. Respiratory acidosis, respiratory alkalosis. Now third parameter is the bicarbonate level. It is alkali. Bicarbonate means alkali. 22 to 28 millimole is the normal range. Millimole per liter. Now when alkali increases, it is alkalosis. It is metabolic component. So it is metabolic alkalosis. If alkali increases, and if alkali decreases, it is metabolic acidosis. So first see the pH. If pH is less, it is acidosis. If pH is more, it is alkalosis. Then second, see for the PCO2. If carbonic acid is more, matlab acid is more, so it is respiratory acidosis. See for the alkali, that is bicarbonate. If alkali is more, it is alkalosis. If alkali is less, it is acidosis. Simple. The parameter who goes with the pH is the primary defect. For example, see if the pH is 7.21 means acidosis, and if bicarbonate is 16 millimole per liter, so this is metabolic acidosis. This is metabolic acidosis. Metabolic acidosis. The parameter who goes with the pH is the primary defect. See, if pH is 7.20 and the PCO2 concentration is 60 mmHg, 60. So this is 60. This is acidosis, and this is carbonic acid increased here. So it is respiratory acidosis. And other parameter is the compensation. Other parameter is compensation. Okay, so this is metabolic acidosis, respiratory acidosis. And DNA repair mechanism, xeroderma pigmentosum and the hereditary non-polyposis colorectal cancer. These are the important clinical cases. Xeroderma pigmentosum, this is blistering freckles, multiple freckles on the skin, sun exposed part of the body. There is blistering skin lesion, and this is a precancerous condition. 1000 times more chances of getting cancer in the xeroderma pigmentosum. This is UV light induced thymine dimer formation, covalent cross-link between adjacent thymine molecule, and this is defect due to the defect in the DNA repair mechanism, that is nucleotide excision repair. Defect in nucleotide excision repair. In xeroderma pigmentosum, there is UV light induced thymine dimer formation occurs, and it is generally removed by the nucleotide excision repair. If there is defect in the nucleotide excision repair, that causes xeroderma pigmentosum, multiple freckles on sun exposed part of the body, precancerous condition, 1000 times more chances of getting cancer. HNPCC, it is due to fault in mismatch repair. It is fault in mismatch repair. Mismatch repair. So if there is fault in mismatch repair, it causes the hereditary non-polyposis colon cancer, which is also known as Lynch syndrome. Hereditary non-polyposis colon cancer. SCID, it is decreased adenosine deaminase activity. Adenosine deaminase activity. In SCID, it is because of fault in double strand break repair. Double strand break repair. The repair is by the non-homologous end joining. If it is non-homologous logous end joining, so if there is defect in non-homologous end joining, it causes the severe combined immunodeficiency where T and B cell both are affected. There is frequent infection, there is a decrease in the uric acid level, there is affected enzyme is adenosine deaminase. It is fault in the double strand break repair, that is non-homologous end joining. So double strand break, it is repaired by two mechanism. One is non-homologous end joining and second is the homologous recombination. If there is defect in non-homologous end joining, it causes the severe combined immunodeficiency where functions of both T and B cell affected, causes recurrent infection, there is immunodeficiency, there is decrease in the uric acid level in the SCID. So this is in short discussion of near about 76 to 80 clinical cases, their key features, their main defect, and the key features, how to diagnose this. These are important for the viva, these are important for the revision of the clinical cases. This is important for some short note revision. Okay, so these are the important clinical cases. Apart from this, meningitis is important. Meningitis, CSF picture and meningitis is important. So remember this 77 meningitis, inflammation of meninges. So in meningitis, mainly the tubercular meningitis, bacterial meningitis or viral meningitis, this is important. Tubercular, bacterial or viral meningitis is important. Remember, this is normal CSF glucose level. It is near about 50 to 70 milligram per deciliter. 50 to 70 milligram per deciliter. And CSF protein, this is glucose, and CSF protein is near about 15 to 40 milligram per deciliter. So this is normal level. Okay, now in the bacterial meningitis, the glucose, CSF glucose can go up to 0. CSF glucose decreases because the cockle, particularly the cocci, the pneumococci, meningococci, they consume the glucose, and the uh, means bacteria consume the glucose. And second one is the response is the neutrophilic here, neutrophilic response. That's why there is the glucose level can go up to 0. Means the 50 to 70 is the normal range. In bacterial meningitis, the glucose level goes 0, and in TB meningitis it can be up to 20, up to 20 milligram in TB meningitis. This is also bacterial meningitis, but this is a special category in which the protein, CSF protein level is much more. CSF protein level is more in the protein. CSF protein level increases in TB meningitis. It is protein level increases in the bacterial meningitis. It is more than 200, and the viral meningitis, it is near about the glucose level low to normal glucose level. CSF protein, it is less than 200 milligram per deciliter. Here it is more than 200. It is much more than this bacterial meningitis in the TB meningitis. So you may get a meningitis, inflammation of meninges, the neck rigidity, fever is there. These are the symptoms. Neck rigidity, fever, high grade fever, neck rigidity, these are the symptoms in the children. and there is affected CSF glucose level, affected protein level. लंबर पंक्चर से CSF कलेक्ट करते, CSF में प्रोटीन और ग्लूकोज इस्टीमेट करते, ग्लूकोज कम हो जाता बैक्टीरियल मेनिंजाइटिस में क्योंकि बैक्टीरिया कंज्यूम ग्लूकोज, और बैक्टीरियल और टीबी बैक्टीरियल मेनिंजाइटिस में पर्टिकुलरली सीएसएफ टर्बिड रहता है बिकॉज ऑफ द कॉकल रिस्पॉन्स एंड द न्यूट्रोफिलिक रिस्पॉन्स इन द बैक्टीरियल मेनिंजाइटिस. While viral meningitis it is clear, viral meningitis it is the CSF is not turbid in the viral meningitis. तो बैक्टीरियल meningitis की क्लिनिकल केस आपको आ सकती बिकॉज CSF is in your competency, CSF is in your competency. So this is all about the important clinical cases related with the biochemistry topic. So it is be confident, don't panic, this is just an exam, this is not a deciding for the life, it is just an examination, it is only a part of life. So all of you be confident, prepare well, keep your mind fresh, keep your mind fresh, keep your mind in the relaxed state, and all of you best of luck and try to attempt all question. This is all about the important clinical cases from the biochemistry. Thank you.